Alright, so we're doing endocrine this week, and we start with acromegalia. I think that's how you pronounce it, but it's the overgrowth of, or the overproduction of growth hormone. This person's got a really nice list of diagnosis, symptoms, and treatment options here, and I have included some pictures to show you Andre the Giant, some famous movie actors, kind of people have had this disease in the past. I also think it's funny that there was all those ads for, you naturally lose growth hormone over time, don't you want it? Well, most people would not think that this was very pretty. Anyhow, just take a look at this. Second one we're going to talk about is Addison's disease, which is low cortisol levels. And got a nice little explanation here of this. One of the things that you need to think about here is cortisol, drawing cortisol levels. Now just remember that cortisol has change in level depending on the time of day. So just keep that in mind, although these will be very low. And this is pretty bad because you don't have the cortisol to fight infection too. So just be aware of that. I include some a little drawing down the bottom here, which is some symptoms that you might want to think about when thinking about Addison's disease. This is not that uncommon, so just be aware of this one, okay? So the opposite of Addison's disease is Cushing syndrome, which is excessive glucosteroids or glucocorticosteroids circulating, and you get the central obesity, hypertension, the moon face, the buffalo hump. Once again, not terribly uncommon. So just kind of think about that. I also included here another little guy to show this. They have the striated stretch marks on their bellies. Well, they've got them down here on his legs, but they have them everywhere as well. So just kind of take a look at this. The next two I'm going to talk about are the Dawn phenomenon and the Samoji effect. They both cause early morning hyperglycemia, but by two different causes. I accidentally erased the Dawn phenomenon sheet, and I will get that back to you before I send it out to you guys. But for the purpose of this video, I thought I'd just include this. The Dawn phenomenon is more to do with growth hormone and other things stimulating hyperglycemia in the morning, where the Samoji effect has got to do with too much insulin at night causing a hypoglycemic event that in turn causes, when the body's responding to that, then it causes hyperglycemia, kind of like a rebound hyperglycemia. So you need to be able to figure out which is which and how to treat them, because they're definitely treated differently. Anyways, just make sure you know these, because these are something pretty darn common in diabetic care. Okay, ketoacidosis, diabetic ketoacidosis, more commonly in type 1 versus the next one we're going to talk about, which is more common in type 2. Some of the symptoms can look just like the differential hyperosmolar hypoglycemic state, which is the one that is a more type 2. It can look just like gastroenteritis, but these people look sick. And I've diagnosed 2 kids with type 1 diabetes in DKAs, not the way you want to get diagnosed. So just kind of look over this. These folks are sick. They need treatment. What happens in a diagnosed person, or at least has been my experience, that knows they have diabetes, they know they're sick, they're not eating, they don't take insulin, they're not taking into account their cortisol reaction to being ill, and that their body's releasing cortisol, so therefore they're using up what little insulin they have, and so they get very hyperglycemic because they've just got all that cortisol, releasing all that glucagon, which is converting into glucose, and therefore they got all this glucose running around in their body, and they're not thinking about that because they didn't eat. Anyways, just kind of be aware of that, and know these folks can get pretty sick, and that really education is key here. They really, if a person is sick, they need to closely monitor their blood glucoses. Type 1 diabetes, most of us are aware of this. We think about this as an autosomal destruction of islet cells. You think about type 1 diabetes also having other autoimmune diseases, like any autoimmune disease. You should be thinking about other autoimmune diseases. So if you have a diabetic, you should be looking for hypothyroidism, you should be looking for celiac disease, that sort of thing. So just kind of be aware of that. It typically occurs in kids, but can occur in adults. So just kind of be aware of that. There's some different theories as to what causes this. Maybe some people think it's like a preset in there, and then they get some kind of virus that kind of sets the whole thing in motion. Does not seem to run in families the way type 2 does, although there is more of a familial tendency towards it. Type 2 definitely runs in families. So now they've got referred to endocrine. If you've got a type 1 that's controlled, that can pretty much be handled by a family practice F&P type person, as long as you're comfortable with that. But if you work with diabetics at all, you should get comfortable with the different kinds of insulin and what they do and how they act. Okay, growth hormone deficiency, kind of like giantism, the opposite end of the spectrum. And these are where people are small. So you might want to read through this. I also included some data to kind of calculate at the bottom here. Calculate height based on parental height. These are important to know because growth hormone deficiency is a problem, and when you have people that are very small for size, you definitely want to check that out. If you have a child that's really small for size, first thing you want to check is for hypothyroidism and just electrolytes, and then you check growth hormone. But most of the time it's just because the parents are short. So you want to be able to calculate where the parents are and then looking at the child to see if that's just the reason why they're short. And then there was a good article, this is where I got that from, and here's an article on growth hormone deficiency in adults as well. So take a look at this. Interesting information. Gynecomastia, in males, really common. It happens in infants a lot. You'll have infant girls with breasts and infant boys with breasts, and sometimes they can even have like a little bit of breast milk. They call it witch's milk. Basically, if you find that, don't express it because you'll just kind of create a cycle and it'll keep producing more. Goes away on its own, usually by 2 years of age at the latest. I have seen it usually a lot sooner than that, but I've seen it up to that point. It is also super common in adolescence, and for adolescents it really needs a lot of reassurance that this is going to be okay. But like she has in her thing here, you probably need to check them every 6 months to make sure it's getting better. If it's not gone in 2 years, then you want to do a little bit more of a workup. So interesting information here. I'm assuming that this tamoxifen is just for cancer. I don't know that it's used for anything else in benign gynecomastia. Hirsutism, super common really with a bunch of different causes, so this is kind of a tough one. But you do want to look through the differentials. Most of them are benign, but there are some that we can treat. So, and then some of it's just genetic and got to do with ethnic origin or ethnicity, I guess it would be the better way to say that. But it can be excessive, so there's some lab work and stuff you can do to make sure that we're not missing anything. We do see this in PCOS. Hyperosmolar hypoglycemic state, typically seen with type 2 diabetics. You can see DKA in type 2s, but this is more common. These blood sugars are a lot higher. I think they have a chart down here that kind of goes through that. No, not so much. These glucoses are above 600, where DKA is more the 300 to 400 range. So kind of be aware of the differences because they are treated a little bit differently. So there's some really good articles comparing the two. If you can't see it by looking at these two, go ahead and look at an article comparing the two. The next one we have here is hyperthyroidism. Definitely much rarer than hypo, which we'll talk about next, but can occur. Typically, you don't want to go crazy with this if you see it's low and they're not symptomatic or very mildly symptomatic. Just repeat the lab work in about 3 to 6 months to see if anything's going on. Of course, if they're very symptomatic, then and their lab work all checks out, then you're going to want to go a little bit more aggressively. But this is something that really does need to be seen by an endocrine because it is fairly rare compared to hypothyroidism, which is about 10% of the female population over the age of 35. So it is very much out there. You'll see a lot of this. You may or may not see the goiter. Hopefully you won't. You'll pick it up beforehand. These people do have the low energy, coarse hair, constipation, dry skin. There could be a family history of this as well. And one of the things you want to check for that is something called antiplatelet, the antithyroid antibody. And what you're looking for is Hashimoto's disease, which is the an autoimmune disease which destroys the thyroid. You do start off with treating this. You really want to get them back in for levels about every. She's got 4 to 8 weeks. So it's really more like 6 to 8 weeks. You want to. Thyroid has a very long half-life, so you really need to have it on board for a while before you check the level. And once again, start low, go slow. This had the elderly patients to go a little bit slower. I am definitely of that school. Hyperthyroidism is a lot more concerning than hypo in the short range, at least. So just be aware of that too. A good thing here for screening, the only thing you need to do is a TSH. You really don't need to do the rest of the study. Low testosterone. This has been getting a lot of hype in the advertising lately for treatment of it. Kind of read through here. These symptoms are kind of vague, but definitely something you need to think about. The biggest thing with treatment with these is that the creams and that sort of stuff really need to stay out of the hands of women, particularly pregnant women. So a lot of the education is if you put this cream on, it definitely doesn't need to be somewhere where they're like on their belly if they're going to have contact with their wife, that sort of thing. So just kind of be aware of that. Metabolic disease, I think we've all heard of this. Super common, unfortunately. Some of the things we look at for is obesity, diabetes, high blood pressure, and potbelly. They have the large abdominal waist measurements, so above 35 for women, above 40 for men. So be looking for that. Super common, really need to be treated with the whole 9 yards, losing weight, exercise, treating their blood pressure, treating their diabetes if they have any. Obesity, definitely a very common, very serious epidemic. Affecting 1/3 of adult population in the United States. Sure seems to me to be more than that. But anyhow, this is something that I think in future years, even in the time that I've been alive, this is going to be a much greater problem, and I can't see it stopping any time lately. So she's got some, or he does, I can't remember who did this, on BMI, like underweight, normal weight, overweight, and then the obese. I don't think we use the term morbidly obese anymore, but it's still there. Anybody with a BMI over 35 with a comorbid problem, anthocyanin, blood sugar, diabetes, hypertension, that sort of thing, is potentially a candidate for bypass surgery. Hypothyroidism can add to this, but it's not the cause of it. It's really eating. I had one poor child who thought she was very overweight, and she did have hypothyroidism, so we started her on medication, and she thought it was going to be the magic bullet to lose all the weight. And on average, from what I've read, is once you treat it, they'll lose 10 pounds. So if you have 40 pounds to lose, it's not the culprit. Pheochromocytoma, a rare kidney involving the adrenal glands above the kidneys. And we don't really think about the kidneys being involved with this, but they're a really important part of it. You kind of think about the adrenals other places. You don't think about kidneys, but anyhow. Some good information here. Just take a look at this. Just be aware of the name. Polycystic ovarian syndrome, kind of like metabolic disease, getting to be more and more common. You kind of look, if you get that metabolic type look and you have someone with irregular periods, be thinking this. So one of the things we might want to do with this is start contraceptives or the birth control pills. I have strong feelings that if you do not do birth control pills a lot, or you don't treat this sort of thing a lot, that you probably need to refer these to a GYN, because there's a multifaceted to this type of problem. And birth control pills are not without problems themselves. I guess the biggest thing here you want to do is promote diet, exercise, and weight loss as your first line defense. Prolactinomia, I think this is interesting, the most common type of pituitary disorder. You can see the symptoms here, differential diagnosis and treatment. So just be aware of this. Nice little picture here. Pituitary does a lot for that little tiny pea shape that it is, right? And then last but not least today is type 2 diabetes. They've got some signs and symptoms here, which I think we all are kind of should be aware of, but they recommend screening for anybody with a BMI over 25 who has at least one risk factor, and I definitely believe that. I screen a lot of kids for this. We're definitely not 40, we're definitely not 45, but have ethnicosis nigrans, have a sedentary lifestyle, who are very overweight, and the amount of kids we have with this or nearly developing this is amazing. We have a 6-year-old right now who her A1C was 6. So she's well on her way to developing this, which is a real shame. Anyways, make sure you look over the this talk. Metformin is the recommended first line treatment for this. I did see one of you guys' preceptors had ordered something else for type 2 as a first line treatment on a newly diagnosed, which I thought it's not standard of practice. Just to be aware, just so you're aware of this, and this is fairly cheap. Anyhow, that concludes our talk for today. I'll try and upload all this stuff for you. Thank you.